So I'm Jean Teasley, and I'm a work in progress in terms of Ehlers-Danlos and the patients with all these kind of issues, because I kind of backed into it by finding a patient who had a problem, and now the floodgates are open. So I am learning as I go, and thanks for inviting me here today, and thanks for teaching me more. So I appreciate that very much. So some of this stuff has been touched on earlier today, but I just want to we can kind of go over this and maybe look at it in some more detail. So the types of EDS with dysautonomia, the thing that really cracks me up is this one. It is joint hypermobility type, and then in parentheses, classic type. I always think that's very entertaining, just because it's like, oh, but just by the by, it's also in that one. In type 4, it's uncommon, but it certainly happens. So the bolded things in cardiac dysautonomia and Ehlers-Danlos are the neurally mediated hypotension, the postural orthostatic tachycardia syndrome, or a combination of orthostatic intolerance when it doesn't fit into one or the other. And if you look at the diagnostic criteria for EDS, joint hypermobility type, these cardiac manifestations are part of the minor diagnostic criteria. And the patients with a joint hypermobility type can have all kinds of other autonomic dysfunction problems, chest pain, palpitations, near syncope, premature atrial complexes, supraventricular tachycardia, and these kinds of things. And Raynaud syndrome and equinocytosis may be part of this autonomic dysfunction. So we had a very elegant talk earlier about GI disease, and so I'm rethinking all my stuff. I was like, well, all these problems are from the GI issues. And then listening to Dr. Henderson, well, all these problems are from the neurosurgical component. And I think it's just still, for all of us, a work in progress. You know, still we're not quite sure where we are with that. So achalasia, gastroparesis, pseudo-obstruction, and constipation are the things that in my patients that I've run across in terms of symptoms. And this also is a minor diagnostic criteria under the functional bowel disorders in terms of diagnosis of Ehlers-Danlos joint hypermobility type. So this article is recent, and I thought it was kind of interesting, but it looked at adults with the hypermobility type, and there seemed to be 3 clusters. The first 2, and I'll show you the graph and talk about it a little bit more. But one of the clusters was the patients that just primarily had musculoskeletal symptoms. So this little peak right here is the cluster 3 with the primary musculoskeletal symptoms. These are cluster 1 and 2, and the gray one of that is the cluster 1, and the black is cluster 2. And basically what you're seeing in there is that cluster 2 is just worse than cluster 1. But it talks about all the other non-musculoskeletal symptoms that you can have, and I know this is kind of hard to see, but sensory motor problems, visual problems, gastro complaints, sleeping issues, fatigue, and on all the things that we've talked about that are not the musculoskeletal part of Ehlers-Danlos. So these are the musculoskeletal symptoms, and these are the non-musculoskeletal symptoms, and seen twice as frequently in cluster 2. You know, and here are some of the autonomic part of it: the gastrointestinal, the orthostatic intolerance, the secremotor problems, thermoregulatory problems. All this is the autonomic part of EDS, problems that you can see in EDS. And then also twice as frequent in cluster 2 are some of the other things that may have other reasons why they have that. And I think all of this just has to be teased out. So 90% of the patients had some non-musculoskeletal symptoms. And cluster 1 and cluster 2, the ones that were the same are psychological problems, cognitive impairments, headaches, and urogynecological problems. And this is an older paper from Peter Rowe. And one of the things, just in terms of going and looking at the literature, it depends on what kind of doctor is writing the article as to what they look at and what they think it means. So sometimes I feel like I'm wandering down a path, kind of go, well, oh, look at that, well, look at that. Well, come back here and look at that. So it makes it hard on some level to try to figure out how to piece it together. But these patients, in response to orthostatic stress, so these were people who had chronic fatigue syndrome and Ehlers-Danlos, and in response to basically orthostatic blood pressures, I think these are probably tilt tables, that they had postural tachycardia or neurally mediated hypotension. And in this particular study, it was kind of half and half, classic and hypermobile. So this is a long list, but just in terms of what you can do for orthostatic intolerance, you can increase the blood volume, you can vasoconstrict, you can reduce tachycardia, you can improve central cardiovascular control with SSRIs and the SSNRIs, clonidine, and facilitate synaptic transmission with pyridostigmine. And of course, the non-pharmacological treatment of orthostatic intolerance, of course, this is the big one right here. But certainly increased water, increased salt, some compression, something to compress the abdomen or the lower extremities. So this is, this was already looked at earlier, but just to kind of go over it from some more. So this was 129 patients that were seen in a neurogastroenterology clinic because they had GI motility issues, and they decided to look at those people and see if they had joint hypermobility. Half of them did. So out of the half of these 65 patients, only 25 have been looked at by rheumatologists for joint hypermobility syndrome. Also kind of interesting, and who makes the diagnosis for all this. But a good percentage of those 25 had joint hypermobility syndrome, not just screening for joint hypermobility, but did have joint hypermobility. So this is also, I think, one of the things in terms of joint hypermobility. They're less likely to have a known etiology. They're more likely to be diagnosed with functional gastrointestinal disorder. They're more likely to be female, though that's younger mean age, and they're more likely to have reflux symptoms. In this article also, the majority of them had fatigue, only half had joint problems, and about a third of these patients had autonomic symptoms outside the gastrointestinal system. So common features between benign joint hypermobility syndrome and functional GI disorders. Chronic episodic pain. They either meet the Beighton criteria or the Rome 3 criteria. They had fibromyalgia, chronic fatigue syndrome, depression, and anxiety. Stuff. And these patients, but esophageal manometry, delayed gastric emptying, and loss of regular propulsion. And these patients also have autonomic nervous system dysfunction, panic disorder, migraine, sleep disturbance, and allergy. So when you look at patients who have benign joint hypermobility syndrome, i.e. Ehlers-Danlos hypermobility type, that I think was because GI doctors wrote this, they used a different term. But for upper GI, they have nausea, regurgitation, reflux, dysphagia, chest pain, and vomiting. And lower GI, they have bloating, abdominal pain, constipation, and alternating bowel patterns. So treatment of GI symptoms, and this also is this is kind of a short list, but treating constipation, the softeners, the osmotics, the cathartics, a peripheral opioid antagonist, methylnaltrexone, which really works very well, but it's not something you can use routinely. And the prostaglandins, pyridostigmine is a cholinesterase inhibitor. So for gastroparesis, we have a list of things that can help. I think this doesn't respond as well as constipation, as however hard it is to treat the constipation. I think the gastroparesis is even more difficult to treat. I've had a couple of my patients go to be evaluated for gastric pacing. Actually, 3 or 4 of them, and a couple of them have already had it, and it's actually been pretty effective. I think that's going to, you have experience with that? Yeah. So there's somebody, a pediatric GI doc in Ohio that's looking at that. All right. So I was also asked to talk about the mitochondrial flavor of EDS. And that is, this is how I backed into this. Because I had a patient who had this whole constellation of symptoms for years. And she's my first patient, but I said, and this, Dr. Barnt, you're still here. My statement to her is, I know you're not crazy. There must be something wrong with you. And so because she had multi-system disease, so this is her. So she was 16, she had headaches, POTS, reflux, constipation, hypermobility type, hyperthyroidism, episodic decline in function. She had myopathic and spastic symptoms and fatigue. It was interesting because she could tell me if her reflexes were going to be increased or not based on how she felt. I haven't quite figured that one out yet, but she's real smart. She's taught me a lot. So her MRI, brain, and lumbosacral spine were normal, and her screening labs for mitochondrial disease were normal. Routine muscle biopsy was normal, and mitochondrial enzyme abnormalities were found on muscle biopsy. She's been very responsive to mitochondrial supplements. She's very responsive to treatment like mitochondrial stress, a metabolic stress. But she has no abnormalities in mitochondrial DNA testing thus far. I think she's probably had about $15,000 worth of those kinds of tests. Right now we've stopped looking. We're going to wait and see. Then my second patient had chronic constipation. This is the one the pyridostigmine fixed. Headaches, he had the hypermobility type, orthostatic intolerance. He had abnormal cortisol levels even though he didn't quite fit anywhere. Fatigue, episodic decline. And this episodic decline, to me, as a neuromuscular doc / mitochondrial person, is one of the things that kind of fits for this mitochondrial disease being the umbrella versus EDS being the umbrella. So I think that it's just still not clear. But this particular guy, when he got sick, in fact, I'm going to try to get him on IVIG, but even changing his port in interventional radiology, he crashed. So that surprised me big time. So he did have a Chiari type 1. He didn't have a tethered cord. He also had mitochondrial enzyme abnormalities. He had postoperative and post-procedure decline, and he also doesn't have any abnormalities of mitochondrial DNA testing. But he also is a crack-up. He fakes neurological symptoms, and partly I've helped him. I taught him some, but I tell him not to do that in the postoperative period. Try not to make everybody worried. He's a great kid. So this question has been raised for probably longer than this, but Dr. Parekh in 1996 said, dysautonomia as an isolated symptom and a genetic mitochondrial disorder is not yet known to occur. There also has been the discussion about, well, if this is autosomal dominant, well, there's no such thing as autosomal dominant mitochondrial disorders. Yeah, there is. One of the CMT type 2. So now they can't say, well, it's not autosomal dominant. But that, I think, just kind of speaks to the fact that this question has been asked and still not answered. And this kind of goes over the stuff. I mean, if you really look closely at patients with mitochondrial disease, about 75% of them have some dysautonomia, so, but not their primary issue. And this was from a recent article by Dr. Cohen, who's a mitochondrial person in Akron. And I think this sentence is very telling. The overlap in symptoms in EDS and mitochondrial disorder may make it difficult for the clinician to distinguish these disorders. No kidding. So I've also spoken to him about my patients, because I have about a half a dozen, maybe 7 patients that I have done muscle biopsies on that have these enzyme abnormalities, that have EDS hypermobility type. I don't know what to do with them because they don't have DNA diagnoses. Is this a secondary phenomenon? And what I was thinking was maybe a secondary phenomenon to all their GI issues, and maybe that's why I'm seeing that. But I'm not sure. Richard Boles looked at, this is something that came out of Cure Mito, but it's also something he's had articles about. So this is patients with mitochondrial DNA abnormalities and functional disorders. So I just thought this was kind of interesting for all these mitochondrial stuff to look a whole lot like the dysautonomia kind of stuff and the stuff that you see in Ehlers-Danlos patients. Migraine, depression, anxiety, irritable bowel, functional abdominal pain, tinnitus, chronic fatigue, attention deficit disorder, TMJ, POTS, chronic pelvic pain. And these, I think, are probably less EDS-like, other than the complex regional pain syndrome. So there are some diseases that are clearly have a lot of autonomic stuff, and probably the most discussed is the mitochondrial neurogastrointestinal encephalopathy disease. And these patients have a progressive gastrointestinal dysmotility and cachexia. And so these are their GI symptoms. They can have early satiety, nausea, dysphagia, reflux, emesis after eating, abdominal pain, indigestion, and diarrhea. They also have a lot of other symptoms that take them out of the primarily autonomic disorder. So they can have ptosis, ophthalmoplegia, ophthalmoparesis, hearing loss, a demyelinating peripheral neuropathy, which in my mind, the neuropathy that this group of patients is getting is axonal, it's a small fiber neuropathy, but this one is demyelinating. And the real trick about this particular disease is that it can present before 10 and before 50, but about 60% of the patients, the symptoms begin before age 20. And the other trick is that any one of these things can be the presenting symptom. So it's not going to be the GI autonomic stuff that's the presenting symptom. They also have abnormal MRIs. They have a family history consistent with Alzheimer's recessive inheritance, which I think is probably kind of hard to say that if you don't have more than just one patient. But there actually is easy, because you can, in terms of trying to diagnose it or rule it out, is you can measure their plasma thymidine or their plasma deoxyuridine. This is an enzyme that is abnormal, less than 10% of the control. And there is a genetic test for this. So if you have these abnormalities and you want to go on with further genetic testing, 100% of those patients have that genetic abnormality. And this is also an older paper, but kind of interesting. So these patients came from a dysautonomia clinic to the mitochondrial people. So it's also, so they came there they looked like they had a hereditary sensory neuropathy. They were hypotonic, kind of interesting if they had joint hypermobility. They had decreased reflexes. They had prominent autonomic dysfunction, but none of them fulfilled the criteria for familial dysautonomia or any other kind of things. So these 3 kids were diagnosed as having a mitochondrial encephalomyopathy, and they had defective activities or decreased activity of the respiratory chain enzymes. And this is the kind of autonomic dysfunction they presented with: GI motility, apnea, which I've seen in a couple of my patients, but not significant, cardiac problems, and lots of other kind of autonomic dysfunction that we have seen in our EDS patients. They were younger at the time of presentation than other of the mitochondrial encephalopathies that had a lot of the prominent kind of things. Their magnitude of autonomic dysfunction was impressive. They have multiple dysautonomic or visual features. And the thing that's kind of interesting is over time, they got better. And there was no real discussion about how they got better or why they got better. But they did. They ended up with kind of a myopathic picture when they were teenagers. So why consider mitochondrial dysfunction? I guess this is kind of the bottom line. You know, am I going to muscle biopsy everybody when I'm not sure what to do with the results? And that's why I've stopped, because I'm not sure what to do. So I'm kind of waiting to see where we are with that. But some of my patients, this first group that I had abnormal muscle biopsy, I used mitochondrial supplements. And these 4 are the kind of top 4. There's the whole mitochondrial cocktail in the old days was like 16 things. Then it shrank. Now it's growing again. So I use leucovorin because I've had some other mitochondrial patients, and this helped them with fatigue. And I found that this helps with fatigue in these patients. The reason it helps with fatigue in the mitochondrial patients is they have a secondary CSF folate deficiency and to their mitochondrial disorder. And so supplementing the leucovorin helps their mitochondria work better. And I've had a lot of my patients who take this tell me that they think that's the one that's the best. So the kind of things that have gotten better, fatigue, myalgias, and minimizing this episodic decline. And I think that's a big key. You know, some of my patients would end up in rehab when they crashed. And so they minimize the episodic decline. So but of course it's hard to say this is what's fixing it, because in the meantime I'm treating all their other symptoms. I'm treating their cardiac dysautonomia, I'm treating their GI dysautonomia. But some of my patients have said that they really think this is helpful. And I do think it is. And the other thing that I've seen in a couple of patients, we were talking about earlier, is surgery a metabolic stressor? Are they having, you know, difficulties post-op because their surgery caused them to crash from a mitochondrial level? Primary or secondary, I don't think it really matters. But use D10, D5 or D10 at 1.5 maintenance. And I think this is the real trick. For patients who do have diagnosed DNA mitochondrial disease, if you look at things like mitoaction.org, you know, they'll talk about continuing the IV fluids like this 24 to 48 hours after they've had a significant improvement, i.e. they're eating, they're drinking, they're up walking around, they look fine, don't send them home yet, don't stop the fluids yet. The other thing is that I find helpful is IV carnitine at 1 gram every 8 hours. You can give riboflavin IV, you can give leucovorin IV. And this, I think, is a problem, because I've seen this happen where people have had surgery, they did well, they crashed on the way home from the hospital and had to come back, and so they were 4 or 5 days out. So I don't know the answer, but I feel like I'm in good company not knowing the answer to this. But I do think it's worthwhile throwing in the mix in terms of what you're doing in terms of management, because the things that you could do to maybe help this are benign. And I don't know what kind of percentage or, you know, it's helping or not, because I can't tell, but I do think that doing this does help some patients. And I will say, take this for 3 months and stop it. And sometimes you find out it is helping, because when you take it away, they decline.